Oh, you still there?
Yes.
Oh, okay. Okay. Ready.
A widowed 37-year-old woman, gravida 3 para 3 comes, or gravida 3 para 3, whose youngest child is 10 years old, has increasingly heavy regular menstrual period for past 3 years. Her last menstrual period was 2.5 weeks ago. She reports a 2-day history of labor-like pains and a small amount of vaginal bleeding. Speculum examination shows cervix is moderately effaced and 2 cm dilated and some beefy red tissue at the os. Which of the following is the most likely diagnosis?
Submucous. Pedunculated.
Okay.
Hmm. Is it the pedunculated? Looks like it. Oh, okay. The answer is pedunculated submucous leoma uteri. Leoma, basic uterine fibroids are benign neoplasm of uterine myometrium and the most common tumor in women. They commonly present with vaginal bleeding, pelvic pain, miscarriage, or infertility, and they are more common in African American patients. Physical exam will show an enlarged, irregularly shaped uterus. In the case of pedunculated intracavitary uterine fibroids or fibroids that grow on a stalk, the pressure on the internal cervical os can cause dilation and effacement of the cervix with protrusion of the fibroid as seen in this patient. Lab studies may show iron deficiency anemia if uterine bleeding is significant. Fibroids are typically well visualized on ultrasound, pelvic ultrasound. They are estrogen responsive, causing increases in size with pregnancy and decrease in size with menopause. Ooh. Treatment includes NSAID or OCPs, GRH agonists, and surgical options such as myomectomy or hysterectomy. It's not carcinoma of the cervix present with vaginal bleeding, classically postcoital, but can be asymptomatic. It's associated with HPV. Physical exam will show exophytic lesion of the cervix, not the mass protruding through the os. Risk factors we already know: smoking, multiple sexual immunocompromise. And it's not sarcoma or the uterus is a rare malignant tumor of the myometrium, presents with abnormal uterine bleeding, pelvic pain, and bloating. It is unlikely to present with dilation and effacement of the cervix as seen in this patient. Mhm.
Okay.
Okay.
27-year-old gravid 27-year-old primary gravid woman at 7 weeks of gestation come to the physician for her first prenatal visit. She has no history of serious illness. Pregnancy has been uncomplicated. She began taking prenatal vitamin 3 weeks ago. Physical examination include pelvic examination shows no abnormality. Lab studies hemoglobin 10.1, hematocrit 30, MCV 72, ferritin is 110. Uh, Iron is 130. I don't know the normal value. Okay,
They are both
normal. Normal, isn't it?
mm-hmm.
Okay, which of the following is the most appropriate next step? Only
Ready?
okay.
So it's hemoglobin electrophoresis. Hemoglobin electrophoresis will be the next There been an evaluation for this patient at an early gestational age who has microcytic anemia with normal iron status. While a mild decrease in hemoglobin is common in pregnancy secondary to physiological increase in plasma volume, hemoglobin concentration less than 10.5 is considered abnormal and should be evaluated. Wait, what's the normal again? Hemoglobin female 12, okay, 10.5. Micro small cytosis defined as MCV less than 80 can be caused by iron deficiency, anemia, sideroblastic anemia, anemia of chronic disease, thalassemia, among other causes. Iron deficiency anemia is unlikely in this patient because she has normal ferritin and iron concentration. Similarly, anemia of chronic disease present with normal to high ferritin concentration and low iron concentration in chronic inflammation. Sideroblastic anemia is much less common than other causes of migraine. It's often related to lead poisoning. Okay. Vitamin B6 deficiency, isoniazid, and alcoholism. It will typically present with increased iron concentration, basophilic stippling on peripheral meal, and ring sideroblasts on Prussian blue stain. Hemoglobin electrophoresis can be used to assess for thalassemia, distinguishing between alpha thalassemia, major or trade, and beta thalassemia, major or minor. And it will be the next most reasonable step. Discovery of one of those conditions may have implications for both the mom and the baby. I want to see alpha globin DNA testing is reserved for patients with suspected alpha thalassemia. These patients often have normal hemoglobin electrophoresis. This will not be the most appropriate first step, but could be considered as confirmatory testing of suspected alpha thalassemia trait after hemoglobin electrophoresis. Okay,
Okay.
next.
42-year-old woman, gravida 2 para 1, 20 weeks of gestation, comes to the physician for a routine prenatal visit. She has tested positive factor V Leiden mutation. Her pregnancy was uncomplicated. She delivered at term by cesarean section for breech presentation. She delivered at term for cesarean section for breech presentation. She has smoked a pack of cigarettes daily for 20 years. She continued to smoke during pregnancy. She does not drink alcohol. She maintains vegan diet. She she owns and manages the vegetarian restaurants. She lives at home. Her partner and son. Temperature normal, pulse 80, respiration 16, blood pressure 100 by 60, ultrasonogram consistent with the size. After 20 weeks of gestation with normal amniotic volume, the placenta is anterior. Distal to the portion, placenta is anterior. Distal portion covers the internal cervical os. Which of the following is the most likely? It is placenta previa, isn't it? And
Yes.
okay,
Ready?
yes,
Okay. So it's previous C-section. Placenta previa refers to abnormal positioning of placenta tissue such that the placenta partially or completely overlies the cervical os. Placenta previa is usually detected, as in this patient, on routine ultrasound. It most commonly presented. It is most common presenting symptom in third trimester. Uh, its most common presenting symptom is third trimester painless vaginal bleeding. Risk factor for placenta fever include causes of uterine scarring, such as multiparity, previous C-section, prior dilation, and curettage. The condition of itself resolves as gestation progresses and the placenta migrates away from the os. If placenta previa persists into the third trimester and to the time of labor, C-section is indicated to prevent significant hemorrhage, maternal fetal complication, and potential fetal demise. Next.
okay. A 36-year-old woman, gravida to para 1, 41 weeks of gestation, has ruptured membrane without contraction for 8 hours. Her infant weight is 4.4 kg at birth. Pregnancy has been uncomplicated except gestational diabetes, which was diagnosed 26 weeks of gestation and had been well controlled with the diet. Initial assessment shows a fundal height 40 centimeter. On ultrasonography, the estimated fetal height is 3.7 kg. Cervix is 2 centimeter dilated, 50% effaced. Fetal heart rate is within the normal level limit. Labor is induced with IV oxytocin. 4 hours later, our cervix is 4 centimeter dilated. 4 hours later, cervix is 4 centimeter dilated, completely effaced. Continuous epidural anesthesia is administered. 2 hours later, fetal heart rate pattern demonstrates late deceleration with each contraction. The contraction occur every minute, lasts 45 seconds, and 75 millimeter mercury at their peak. Which of the following is the most likely explanation for this pattern?
Oh, so late deceleration, that will be Leville chop, placental insufficiency. Uh, what can cause placental insufficiency? Hmm, I don't know. Ready?
Yes.
Oxytocin administration. Oxytocin is frequently given to induce and augment labor. It acts by stimulating uterine contraction, which in turn leads to progressive dilation and effacement of the cervix. It is also used after delivery to induce uterine contraction in the setting of uterine atony and postpartum hemorrhage. However, when a patient receives too much oxytocin, hyperstimulation and tachystoly of the uterus can occur, tachysystole, in which the uterus contracts too frequently without adequate relaxation time, more than 5 contractions per 10 minutes. Okay, often with prolongation and intensification of contraction or lack of return to resting tone. These contractions can cause compression of the placenta blood vessels, leading to uteroplacental insufficiency and fetal hypoxemia. This often presents with late decelerations and fetal heart rate racing, or gradual decrease in the fetal heart rate that begins after peak uterine contraction. Treatment includes the discontinuation of oxytocin, followed by close monitoring of fetal heart rate racing to assess for resolution of the late deceleration. If the late deceleration persists after cessation of oxytocin, there may be an additional cause for uteroplacental insufficiency, and urgent C-section may be indicated for persistent fetal hypoxemia. Another complication of uterine tachystole is uterine rupture. Epidural anesthesia can cause uteroplacental insufficiency and fetal hypoxemia if the epidural results in maternal hypotension. It is unlikely to cause late decelerations in the absence of low maternal blood pressure. What is for blood pressure? It didn't give the blood pressure. Okay. Okay. But and does not cause changes in uterine contractions. Okay. Gestational diabetes increases the risk of uteroplacental insufficiency and is associated with late decelerations. It can also cause preterm labor, polyandral microcephaly. It does not cause tachystole. Okay, tachysystole. Post-date pregnancy can be associated with microsomia, oligoandanios, uteroplacenta. However, given the change in uterine contraction with the initiation of oxytocin administration is the most likely cause of the late deceleration. So tachysystole is more than 5 contractions in 10 minutes. Okay. Okay.
Okay. A 42-year-old woman Comes to the physician because of 3 months history of urinary urgency and frequency with occasional incontinence. 2 months history of numbness below the waist. She has had to get up at least 3 times at night to void. She has had a fever, pain with urination, cloudy urine. She has a relapsing and remitting MS. Symptoms have included double vision 10 years ago and right-sided weakness for 3 years. Sensation to vibration is decreased over fit. Deep tendon reflex are 3 plus. Urinary normal. PVR normal. Post-viral is 45. Which of the following is the most likely diagnosis?
Ready?
Yes.
With a drusen hyperreflexia. Urge incontinence most commonly occurs because of the drusen hyperreflexia or overactivity. Typically presents with the urge to urinate followed by leakage of variable amount of urine. Is most commonly associated with neurologic disorders like MS, spinal stenosis, spinal cord injury, but may also be idiopathic. Physical exam and lab studies will show no abnormalities. Post-void urinary bladder residual volume will also be normal. When evaluating urinary incontinence, however, it's important to rule out an associated UTI, especially when urinary incontinence is new in onset. Treatment of urge incontinence includes strengthening the pelvic floor, weight loss, minimizing caffeine and alcohol intake, bladder training, and time voiding, and oxybutynin. The trusor hypotonia results in overflow incontinence caused by inadequate contraction of the detrusor muscle to overcome the urethral sphincter, which is commonly associated with spinal cord injury and autonomic neuropathy. Overflow incontinence may also occur secondary to external sphincter hyperactivity. Wait, overflow incontinence. Okay. Which can result in bladder outlet obstruction, along with other potential causes. Okay, don't understand that one, but okay. Next.
A 32-year-old primary gravid woman at term has a cervix that has remained 5 centimeter dilated over the past 4 hours despite the administration of 5 centimeter dilated over the past 4 hours despite administration of oxytocin. Contraction occur every 3 minutes and are 55 to 64 millimeter mercury intrauterine pressure catheter measurement. Examination shows somewhat molded vertex and caput succedaneum. Which of the following is the most likely diagnosis?
Abdominal contraction, active phase, latent phase. Ah,
It is not arrest, isn't it?
that's what I thought it was. Okay, now that you're saying it's not.
No, no. if arrest happens, like for primary, for 4 hours minimum, less than 1 to 2 centimeter dilation, but he has, wait, remained 5 centimeter dilated over 4 hours. So it has not dilated, isn't it?
It has it's
Five.
dilated until fives only. Yeah,
Yes, so it may be arrest.
I don't know how I'm confused on that one. I'm between A and B, and actually C.
Okay.
Ready? Ready?
Yes, I think
Mhm.
it's arrest.
Okay. Arrest of active phase. Labor consists of three defined stages. The first stage is divided into latent and active labor, encompasses the start of labor, so when it is contraction and cervical changes, until the completion of cervical dilation and effacement. So I'm guessing latent is okay anyway. First stage, cervical change and cervical dilation to until 10 centimeters. The second stage include the time from complete cervical dilation to newborn birth. Okay, so when the baby is passing through the vagina. And the third stage is the delivery of the placenta. The first stage of labor is considered latent until the cervix is 4 centimeters dilated. Okay, okay. So first stage when the cervix is opening, latent phase until 4 centimeters, after which the rate of cervical dilation increases and the patient is in active
First
labor.
stage is like onset of true labor pain to the full dilatation of the cervix, isn't it? And second
Yes,
stage is full dilatation, like complete cervical dilatation to up to neonatal birth is second stage. And complete full dilatation is 10 centimeter. And the third stage is like delivering the placenta. Okay.
okay. So the first stage is divided between latent, which is 0 to 4, and
Yes,
active,
early
which is,
latent and full latent. Okay. Late latent.
wait, oh, no, it's latent and active. Mhm. The active stage of labor can be protracted, which occurs when the cervix is dilating at less than 1 to 2 centimeters per hour. It can also be arrested, in which case there is no cervical change for greater than 4 hours with adequate contractions. Okay. Or there is no cervical change for greater than 6 hours with inadequate contraction. Protraction and arrest can be caused by hypotonic contractions, cephalopelvic disproportion, and non-occiput anterior fetal presentation. Okay. Inadequate contractions occur less than 3 to 4 times in a 10-minute period with a strength of less than 200 Montevideos. Both cephalopelvic disproportion and non-occiput presentation can cause molding of the fetal head and caput succedium, as seen in this patient. Protraction of the active phase of labor can be managed with oxytocin to augment uterine contraction and prostaglandin to assist in cervical ripening, whereas arrest of active phase of labor is managed by C-section. It's not hypotonic contractions can cause protraction of or arrest of the active phase of labor. However, this patient is having adequate uterine contracted as she's having 4 contractions in a 10-minute time frame. Where did he say? Where did he say 4 contractions? I don't know. Okay, with adequate contraction strength exceeding 200 Montevideos. They're just making up stuff now. And it's not protected latent phase or of labor occurs when cervical dilation does not occur as rapidly as expected in the latent phase of labor. Although the length of the latent phase is highly variable between patients, as this patient is already in active labor, given her cervical dilation, the choice is incorrect. Okay, okay. Next.
Yes. A 32-year-old woman, gravida 5, para 4, 40 weeks of gestation, is brought to the emergency department because of bright red vaginal bleeding for an hour. Contraction has occurred for 2 to 3 minutes for 5 hours. Her pregnancy has been uncomplicated. Ultrasonography is at 22 weeks of gestation showed no evidence of placenta previa. Her temperature normal, pulse 120, respiration 18, blood pressure 90/60. Okay, hypertension, tachycardia, tachypnea. Not tachypnea. Physical examination, tender abdomen with a firm uterus. Fetal heart rate is 140 per minute normal. There is copious red bleeding from the external cervical or cervix is 4 centimeter dilated, 80% effaced. Physician informs that her husband that emergency cesarean delivery is recommended. The patient and her husband state that because of religious belief, the elders of their church must agree to surgical delivery because before they can leave their consent. Which of the following? Okay. Uh, this
Oh,
is a bit confusing.
because I don't know. Because it's an emergency, so there is no time to call the elders of the church. I mean, that would make sense, but it's kind of an emergency. Obtain approval from the hospital administrator.
Is it
I don't know.
possible, like hospital administrator?
I don't think so.
Okay, let's see what they want.
Oof, I guess it was an emergency. Ask the patient to convene a meeting of the church elders to discuss C-section. I guess it's not an emergency. According to
Caesarea section is the emergency. I don't
Jesus.
know.
I mean, I would
Look
have
at the
picked that
look
one,
at the
but
patient's BP. Patient's BP is falling. Patient is
it's
not.
falling. Yeah, that's what I thought. Like, okay, it's an emergency. That would have made sense if it wasn't an emergency. But I was like, it's an emergency. If we have to bring all these elder people to, I mean, anyway. According to the ethical tenet of an autonomy, the patient has the right to convene a meeting of the church elder to discuss C-section and potentially decline the surgery. Okay. Patients are assumed to possess decisional capacity unless they demonstrate otherwise. These patients should be assumed to have decisional capacity since she has no cognitive or psych reasons to suggest the absence of capacity. Her husband agreement supposes that the patient is making a decision that is typical for her and does not reflect an absence of decisional capacity. Patients who possess decisional capacity have the ethical right to decline procedure even if the procedure are emergent and involve the uterus. Oh, and involves a fetus. Okay. In patients who lack decisional capacity or are unable to communicate the decision about an emergency procedure, the ethical principle of beneficence should prevail, and the physician should save the patient's life. Having an advance directive that clearly states that the patient would not want the emergency procedure constitutes the exception to the rule of saving the incapacitated patient's life, as it can be assumed that the patient possessed decisional capacity at the time that the advance directive was written. It is not appoint a guardian ad litem for the fetus to consent for C-section or obtain approval from pediatric staff to perform emergency C-section will violate this patient autonomy to decide what procedures are performed on her body, which takes precedence over fetal concerns. Guardians ad litem are appointed for adult patients who are incapacitated, lack family members who could serve as surrogate decision makers, and need to consent to urgent or emergent um, procedure. Obtain approval from hospital administrator to perform emergency C-section. will constitute a violation of the patient's autonomy to decide about the surgery. Hospital administration may be involved in decisions the medical team makes about incapacitated patients to navigate legal or systemic concerns. Okay, you want to
Not
stop?
satisfied. Okay.
You're
I'm not
um,
satisfied with this answer. Not have
basically,
very,
basically,
very
i-
bad answer.
if the baby, because my tutor told me to, if the baby is still in the stomach, even if
Yes.
the mom says something to kill the baby, you have to do it. If the mom
If,
says,
if the
uh huh,
baby does not like, the baby has a life, isn't it?
the baby has what?
The baby has a life. If it like think in this way, like if we can do whatever moms like, then
But
then it's near to killing,
yes,
isn't it?
yes.
So what, I don't know how this type of thing makes sense.
Oh
In
no. So
okay,
so basically, what while the baby is still in the stomach,
yes,
the mom has the right to kill it, to let it live. The mom has the decision. So if the mom says kill the baby, you have to kill the baby. Okay, it's not like that in real life, but in the exam, if the mom says kill the baby, you have to kill it. If the mom says don't do the procedure, even if you know it's going to kill the baby, you don't do the procedure. You kill the baby because the baby is still in the stomach. Now, then once the baby's out of the stomach, even if it's for like 2 seconds, the baby's out. Now you
okay,
have to do, even if the mom says kill the baby, you cannot kill the baby because the baby is already out of the stomach. So it's not responsibility of the mom
okay,
anymore.
I got it. I got the concept.
Yeah, standardized one.
Okay, let's do four questions from the
Mhm.
past.
I think it was the, never mind, not this one. I think it was the 1215. Oh, I didn't even read that. Attributable risk.
Risk.
Hmm.
Okay, I'm reading. If you don't want to read the
I
explanation,
thought,
I can read it too.
read the
No problem.
explanation.
Because you don't like the
I
explanation to
don't
read.
like those explanations.
But the questions are important. I feel that.
Mhm. Yeah.
Okay. In a small observational study, 100 100 industrial workers are followed for 1 year to assess the development of respiratory symptoms defined as productive cough lasting at least 1 week. 30 of the 60 smoker experienced respiratory symptoms versus 10 of the 40 non-smoker. Which of the best estimate attributable risk AR of this respiratory disease? 30 over 60, minus 10 over 40,
Workers.
10 of 1 by 4,
Jesus.
4
Attributable risk
into
in smokers. 30 over 60. 10 over 4. Let's see. 0.5. 10 over 40. 0.5 over 0.25. Oh, Lord. Maybe between 100.
attributable risk is
Oh,
0.25. Okay.
okay. I'm just going to go with this one. I did not read this. I don't want to waste time This I do not know.
Okay.
Okay.
Oh, okay. In a small observational study, 100 industrial workers are followed for 1 year to assess for the development of respiratory symptoms. 30 out of 60 smoker respiratory symptom over years and 10 what percentage of the respiratory what percentage what percentage of the respiratory disease experienced by smoker is attributed to smoking? So our answer, so we need to find out the percentage.
Um, yes. I don't know. This is. I have not reviewed this. I'm not going to kill myself. Mm,
Okay. Research for okay. In a
mhm.
small observational study, 100 industrial in a small observational 100 industrial workers are followed for 1 year to assess the development of respiratory symptoms. 30 of the 60 workers experience respiratory symptoms and 10 of the fourth. What percentage of the respiratory experience all study subjects is attributable? What does it mean? Okay, give an answer and we will move
This is
forward.
so smart.
The words are the I think that the this math is not that tough, but the words are very complicated.
Okay, so it's like ah okay. Let me just give this is I'm lost in this one.
You were keeping everything 50-50.
Yeah, just give
No, no, it's a very wonderful idea. A new chemotherapy regimen used in patients with ovarian carcinoma is tested in a small clinical trial. Out of 50 patients treated with the new regimen, 25 survived 5 years without relapse. Out of 100 treated with the conventional regimen, 25 survived 5 years without relapse. So 25. Okay. How many patients needed to treat with the new regimen as opposed to the conventional regimen in order to, okay, 5 years. Number needed to treat divided by absolute risk reduction. Is exposed
reduction.
25 conventional, 25 out of 100 on the conventional, and 25
5 over 50, 0.5. That's 0.5 over
out of
um,
100 patient with the conventional regimen,
uh,
25
the, uh, 0.5 and
out of
0.5.
50 patient out of 50 patient treated with the new regimen.
1 over 0.1 over 0.25. 4. Okay.
By 4 of 0.25 on the 4. Okay.
Okay. Answers. Oh Lord. But I was right in 150.
The first one.
No, the second one.
Your 50-50
Okay.
things works. Okay, I'm reading the explanation. Let's. Okay, the first topic is attributable risk, or another name, risk difference. Okay, attributable risk or risk difference. It is a measure of excess incidence of disease due to a particular factor. Excess incidence of a disease due to a particular factor exposure. In question 1, the 1 year incidence of the respiratory disease in the smoker is 30 by 60.5, whereas non-smoker 10 by 40.25. The difference between these incidents is 0.25 describes the attributable risk. Based on the calculation, we can assume 25 out of 100 respiratory disease are attributable to the smoker. Okay, so number one, a related measure. You got this?
Yeah, I think so.
Okay.
Yeah.
Previously, you made this thing. You made me understand these things.
Oh,
You don't
good.
remember?
I don't remember, but
You gave the video of that person.
I
That
haven't talked biostat since we finished biostat.
I have told you earlier that it will happen. I know that. It looks like it is a new thing, isn't it? Okay.
Mm-hmm.
That time you were very good in Bastard on
Mm-hmm.
those days. Okay. A related measure known as attributable risk percent describe the contribution of a given exposure to the incidence of a disease in relative terms. Attributable risk percent ARP is calculated by dividing the attributable risk by the incidence of the disease in the exposed population in smoker. In question 2, we calculate the attributable risk percent, that is attributable risk percent, that is 50%. So how we can calculate? Okay, I got it. So risk exposed minus unexposed divided by risk exposed.
Okay.
You got it?
Yeah.
So that's how we got the percentage.
Mm-hmm.
Okay. Another measure, another measure called the population attributable risk percent describes the impact of the exposure on the entire study population. In our case, both smoker and non-smoker, to determine the population of attributable risk percent. First, calculate the incidence of the disease in the study population as a whole. In the above study population, 30 smoker and 10 non-smoker who develop respiratory disease, total 100 workers, 60 smoker and 40 non-smoker. Therefore, overall incidence of developing respiratory disease in the study is 40 by 100. Next, calculate the difference in the risk in developing respiratory disease among the study population as a whole among the non-smoker. 40 by 100 minus 10 by 40 is zero point 0.4 minus 0.25, it's 0.15. Divide this value by the incidence of the respiratory disease in this population as a whole. 0.15 by 0.04 is 0.375. Based on this calculation, we can conclude that 37.5% early respiratory disease in the study population. I don't get this part. I can
Mm-hmm.
calculate number needed to treat the question 4, but I don't understand the question 3.
I don't understand the question three also. It's called what? Population attributable risk percent. Population.
Okay,
Okay.
I am reading this again. The,
Mm-hmm.
let's look. Let's think. Okay, population attributable risk percent. Okay. In the above study population, there are 30 smokers, 10 non-smokers who develop the respiratory disease out of 100 total 100 workers. In the total 100 workers, 60 smoker and 40 non-smoker. Therefore, the overall incidence of the developing respiratory disease in the study is 40 by 100. 40 by 100. Next calculate the difference of the risk of developing respiratory disease among the study population as a whole. 40 by 100 minus 10 by 40. How it is calculated? 0.15. I don't know how to do it. Okay, I am reading the last. Number needed to treat, we know this formula. Number needed to treat is like if you this risk exposed minus unexposed, then 1 divided by absolute risk reduction. Okay, it is important concept related to absolute risk reduction is number needed to treat. It is actually the reciprocal of the ARR. It answers the following: how many of the patients should I treat with the drug of interest to save or extend of one life? The death rate in this place of new treatment is 25 by 50, 0.5 over 5 years, whereas the conventional chemotherapy is 75 by 100, 0.75. The ARR is 0.75 by 0.5 is 0.25. Okay, the reciprocal of the ARR 1 divided by 0.25 is 4, reveals the NNT. You got it?
Wait, why they did
Sorry.
70, why they did, I get why they did 25 over 50, say here 25 over system, but why they didn't do 25 over 100 here? Why they did
I
20?
have the 25 over 100 and the answer is same.
Okay, okay, then it's fine then.
Okay,
That's
so
right.
we missed an important concept ARR.
The no, that's not ARR. That's like